Thank you so much for Dr. Park and all of the organizers for inviting me to talk. I'm going to give just a short overview of some of the research that I've been doing that I hope is of interest to you. My talk is called Measuring Epileptic Networks. A couple of quick disclosures. I do have some research funding from the Better Foundation and from the NIH, and I do very little consulting for BioMarin or Marinus, and neither of those consulting jobs have been related to anything I'm going to be presenting today. So my research interest is in epilepsy surgery and the outcomes that we see as well, both in terms of seizure freedom and in terms of cognitive outcomes. As you likely know, about 3.4 million Americans and as many as 50 million people worldwide have epilepsy, and about a third of those individuals will be refractory to medications. And in some of those individuals, cortical resection has the potential to cure their seizures, but the success with this varies widely, and there are a lot of reasons for that. When we're thinking about doing an epilepsy surgery, the goal is to find the part of the brain that's causing the seizures and to remove it or to ablate it or to stop it from communicating with the rest of the brain and causing seizures. And what we think of conceptually is of that region is that it's the epileptogenic zone. And this is a zone that we can't actually define. We don't have any specific measurement that says, this is it, this is where you need to be. But we use a lot of different studies as proxies for it. So for an example, we have the irritative zone, and this is where on the EEG, we see these spikes, and it shows that the cortex in that region is generating aberrant electrical activity, and it suggests this could be the area where the seizures are coming from. Or on the MRI, there might be some sort of scar or lesion. I apologize for my slides auto-progressing. There might be some sort of lesion there or a scar that could be generating the seizures. And then we look at the seizures themselves, the symptoms that you have and how they evolve, and that suggest it must be this part of the brain that's involved first, and then it extends. But we also know that epilepsy is a network disorder. It causes a pathological network within the brain that can spread out. And sometimes it involves these areas that cause seizures or irritation, and sometimes it can lead to deficits outside of those regions as well. And so this concept of epilepsy as a network has led us into this increasing interest in the study of functional connectivity, a term that you may or may not have heard of. But it's increasingly popular, and it's a technique for studying the brain across a broad variety of different neurological disciplines. I looked at this a couple of years ago, just studies of functional connectivity in pediatric epilepsies. And you can see along the bottom here, the x-axis is years. And over the last decade, it's just been a massive growth in interest and research in this area, just in pediatric epilepsy. And this curve would look the same in adult epilepsy among any other neurological condition. But what is functional connectivity? So the definition that I ran across that I liked a lot was this one, that functional connectivity is the inferred relationship between two different anatomic regions based on their co-varying neurophysiological activity. And I asked my wife what she thought, and she thought that it was horribly convoluted and didn't make any sense. So I have an example for you. This is an image from an MRI, and this is a functional MRI, which uses something called fold sequencing, which is looking at blood flow patterns in the brain.
Dr. Bear.
Oh, yeah.
I'm unable to see your screen.
Oh, really? Oh.
Yes.
Oh, man. Okay. Can we restart everything then?
Sure.
Let's see. I see. You texted me. Ah, yes. Okay. So you'll restart the recording?
Mm-hmm.
Let me try again.
I can go back and edit it for the week, so.
Okay.
Perfect.
See it now?
Yes.
All right, I will start over.
Thank
Let me
you.
figure out then why, give me 1 second then. Let me figure out why this one is auto progressing. Do you know quickly offhand how to stop a slideshow from going automatically? I don't use timing. Don't play directions.
What are you utilizing? Just Microsoft PowerPoint?
Yeah.
It should be a, yeah.
I'll give it a moment. It was not fast, but it was progressing by itself.
In that bottom left-hand corner, does that allow you to turn that off, the presentation mode?
Let's see. These, it's got a couple of options on there. It looks like it's not progressing. I think maybe I stopped it. Okay.
Okay.
I'm gonna do this. Oh no, that's probably not going to work. Now do you see everything? That's fine.
Mm-hmm.
Okay. All right. So I'll get restarted.
Thank
Who should
you.
I thank? I was just going to thank KP and
That's perfect.
who puts it on, like the Epilepsy Foundation? Or?
The Epilepsy Foundation and Dr. Park.
Okay. All right. Should we get started again?
Yes.
Thank you so much for inviting me. I'd like to thank Dr. Park and the Epilepsy Foundation for putting together this wonderful program. I'm Joshua Baer. I'm one of the pediatric epileptologists and researchers at Children's Hospital of Colorado. And I'm going to talk to you about some of my research measuring epileptic networks. As a disclosure, I do have some funding from the Betcher Foundation and from the NIH for my research. And I've done a very tiny amount of consulting for BioMarin and Marinus, and none of that consulting work relates to any of the work that I'm going to be showing you today. My main research focuses on epilepsy surgery, both in terms of the outcomes that we see for seizure freedom, as well as the impact on cognition. And that's the area that I'll be talking about. As many of you know, about 3.4 million Americans and at least 50 million people worldwide have epilepsy, and about a third of those will be refractory to our medications. And for those, cortical resection, or taking out the part of the brain producing seizures, has the potential to cure their epilepsy, but the success varies quite widely. We see certain epilepsy types, such as hippocampal sclerosis and mesial temporal lobe epilepsy in adults, having success rates as high as 80 or 85%, whereas in some frontal lobe epilepsies in children, our success rates are as low as 30%. And clearly, there's a lot of room to make improvements here. When we're thinking about doing epilepsy surgery, specifically for resections or ablations, the goal is to find the epileptogenic zone. And this is a concept rather than a measurable entity that represents the part of the brain that needs to be removed in order for an individual to achieve seizure freedom. But there's no way for us to know exactly where this epileptogenic zone is. And so we use a lot of other studies to try to help us estimate it. So some of the other zones that we think about are the irritative zone. And what this is the part of the brain that produces epileptic spikes like we might see on an EEG. And we know that the part of the brain that's producing these spikes is more irritable and is more prone to having seizures, but we don't actually know if that's where the seizures are coming from or not. And similarly, we'll look at an MRI and look for lesions, right? A scar or a sign of an old infection, or a part of the brain that just grew a little bit differently, such as producing a malformation of cortical development or something similar. And again, these lesions are often a source of seizures, but not always. They overlap with this epileptogenic zone, but not completely. And then finally, we'll look at the symptoms that an individual has while they're having a seizure. So when a seizure starts, what is the first symptom that they get? Is there an aura that they experience that might give us a clue as to what part of the brain is involved in generating the seizures at the very beginning? And we'll use all of this information to try to predict where the epileptogenic zone is. Now, there's this increasing interest in studying epilepsy as a network disorder, and there are a lot of different reasons for that. But one of them is that we also know that individuals with epilepsy can have cognitive challenges or difficulties that extend beyond the part of the brain that we know is producing the seizures. And we call this the functional deficit zone. And this is, again, a representation of the epilepsy being this pathological network that can really extend across much of the brain, far away from just the lesion or just the irritative region. And one of the tools that's been emerging to study epilepsy as a network disorder is something called functional connectivity. So functional connectivity is increasingly popular, and it's great for epilepsy. It's great for basically any neurological condition. And it's increasing rapidly in popularity. So this is a paper I published just a couple of years ago, and I suspect that this trend has continued. Along the bottom, we have the year increasing, and the y-axis is the number of publications. These are specifically in functional connectivity studies in pediatric epilepsies, but this curve would look the same in any other type of epilepsy or any other neurological condition. But what is functional connectivity? So I ran across this definition and I thought it was great. The functional connectivity is the inferred relationship between two different anatomic regions based on their co-varying neurophysiological activity. And I showed it to my wife and she said it didn't make any sense at all. So instead, I have an example for you. And this is a MRI slice from a BOLD sequence. So BOLD stands for blood oxygen level dependent imaging. And it's a way of looking at blood flow in the brain. And when you see anybody talk about fMRI or functional MRI, these are the images in general that they're talking about. And if I play this video, it's subtle, but you may be able to see that there are these little fluctuations in the intensity of the squares as it moves forward, right? And those are subtle fluctuations in the blood flow to those brain regions. So if we were to take two regions of interest, in this case, I'm going to take parts of your primary motor cortex and look just at the fluctuations in both of those areas and plot that over time. So here along the x-axis, I have your time in minutes. This is a fairly long scan. And on your y-axis, I have the intensity of that signal as it goes up and down. And we can plot that signal. And over this long time frame, in these two parts of your motor cortex in the left and the right hemisphere, you can see that the curves overlap a lot, right? They sort of go together. And that's functional connectivity. That's areas that are oscillating or moving in similar ways across time. And for the brain to do that, for different parts of the brain to be oscillating in unison like that, those regions have to be connected somehow, right? There's either some anatomic connection that directly brings them together, or maybe there are other hubs that are controlling both of them at the same time, but they're functionally connected. They're having the same physiological activity. And so we'll assign a statistical value that says this is how functionally connected these regions are. And there's a whole sort of literature trying to decide, when that number matters and when it doesn't. But that's the basics of what functional connectivity is. And so this is one of the main things that I've been studying, but on a much different time scale. So what we just looked at was a 12-minute time scale. And what I've been interested in is looking at these spike-associated networks. So these are parts of the brain where the functional connectivity increases momentarily, just as these epileptic spikes occur. And on this, this tracing here is from an MEG or magnetoencephalography. It looks very similar to what it would look like on an EEG or electroencephalography. And this spiky thing here is an epileptic spike. And so what we did is we looked at a 1 second period before the epileptic spike, and we looked at a 1 second period after the epileptic spike, or containing the epileptic spike and then the immediate period after it, and asked what types of changes in the brain's connectivity occur between these two time points. So this image is a whole brain connectivity graph, and I'll take a moment to explain it. Basically, the whole brain for this individual has been broken up into 360 different functional regions. And each one of those regions is represented, is given a number between 0 and 360. And the numbers go both along the y-axis and along the x-axis here. And if you take one region of interest, say region 50, and you draw a line across it to another region of interest, say region 150, and you look here, then the color at that spot, at their intersection, represents how connected those regions were in the pre-spike period. And then we do the same thing and we look at it on the spike period. And the red colors, you can see on this color bar, the red colors are going to be more highly connected regions, whereas the blue ones are going to be less highly connected regions. And during this individual's spike, you can see there's all this extra red and deep orange that's come out, indicating that these regions during a spike are much more highly connected to each other. And the idea here was maybe if we can look at all of the regions that are connected during a spike, then maybe we can get a proxy for the epileptic network. And so we took these images and then plotted them onto a brain. And for this individual, that plot looks like this. And so again, the color bar, the red ones are these really tightly connected ones, whereas it gets down to the yellows and the greens, they're functionally connected, but that number isn't quite as high. And then I've pruned out all of the ones that were very low connectivity, assuming that they're not relevant in this case. And you can see that this individual had a, had a network that had these high connections up here in the frontal lobe. They came back to a supramarginal gyrus into a bunch of areas in the temporal lobe. And this was a non-invasive study, right? This is the MEG. And so your head sits in a helmet and measures your electrical activity for a while. And then we're able to generate this image and look at what we think is the epileptic network. But then the question is, does it matter? Is this relevant or not? And so this individual ended up having something called stereo EEG, which is an intracranial EEG, where we insert electrodes through the skull and into the brain to measure the electrical activity that's happening in different parts of the brain. And when we did that, we saw that indeed her seizures arose and the most active or electrically active parts of the brain occurred in the spots that were really highly connected. So here in the temporal lobe, here in the supramarginal gyrus, and here in the temporal lobe. And it validated that this was, at least appeared to be, a reasonable assessment of the epileptic network itself. And so we looked at this in 9 different subjects and found that there was considerable overlap in all of these subjects between what we saw non-invasively and what we saw invasively. We also saw that the spike-associated networks also often included a broader anatomic distribution than what we sampled with the stereo EEG, and there's no way to know whether that was relevant or not, because if we don't put an electrode in that part of the brain, then we don't know what's happening in that part of the brain. But the fact that it shows this considerable overlap could help us in planning where to put these electrodes, because we could say, well, we know that there's a lot of overlap here, and this looks like it's a highly connected region, so we probably should drop an electrode in this spot and measure it as well. At least that's my hope. But there's still some work to do to say, is it just the ones that have those red edges, or is it ones that are connected to more regions? And there are a lot of different ways of analyzing it and questions to ask with that, but that's sort of where we are. So the next step was to take those non-invasive studies of looking at these spike-associated networks and say, okay, well, this seemed promising. Can we also measure spike-associated networks from intracranial EEG? So when we're getting those EEG recordings from the electrodes in the brain, can we look at where the spikes propagate from one electrode contact to the next? And is that useful information? So for this study, we looked retrospectively at 22 children who had undergone a stereo EEG, and then who had either a resection or ablation of what we thought was the epileptogenic zone, and who had at least a year of clinical outcomes. So we could say, okay, when we did that surgery, did they have a good outcome? Were they seizure-free, or were they not seizure-free? And we used a type of functional connectivity measurement called the phase slope index. The only thing that you need to know about that is that instead of just saying these 2 regions seem to be connected, it tells us the direction of that connection. It says, okay, these 2 regions are connected, and it appears that the activity in this part of the brain is driving the activity in this part of the brain, or it's going from here to here. And we asked the question, if we resected those parts of the brain that were sending the most information out during spikes, did that predict seizure freedom? Or if we left them behind, did that predict a surgical failure? So in this image, we've divided the patients into 2 different groups. We have the subjects who were seizure-free and those who had persistent seizures after the surgery. And each of these dots represents one electrode contact. So when we do stereo EEG, we put this electrode through the skull and into the brain, and it can have anywhere from 8 to 16 different little electrode contacts. And each one of those is measuring activity from the brain. And so each dot is each one of those. And there were a bunch of them, right? In 22 patients, we had a few thousand different electrode contacts that were included. Now, along this y-axis here, I have the connectivity value, the outflow connectivity value for those contacts. And so what this is a measure of how much information was leaving one electrode contact and going out to the rest of the brain, with the idea being that the parts of the brain that have the spikes or that are the most irritable we're probably sending information out to other regions of the brain, and maybe those are the ones that need to be evaluated and then possibly resected. And so up here, I've only taken the ones that have the Z-score of 2 or greater. So these are the ones that had a lot of information outflow. And then they've been colored differently. So the blue ones were included in the patient's resection, and the red ones were not included in the patient's resection. And what you may notice is that in the subjects who are seizure-free, there's a lot more blue. And in the subjects who are seizure persistent, there's a lot more red, meaning that in the patients who are seizure-free, we had resected the majority of those really high outflow contacts. And then the patients who had ongoing seizures, we had left those really high outflow contacts behind. And if we graph this out on a curve to look at what we call the positive and negative predictive value, we'll get curves that look like this. So the blue line is the positive predictive value. What that means is if we do resect these electrode contacts, or the brain around these electrode contacts, what is the likelihood that an individual is going to be seizure-free? And as we go up, in this case, the x-axis is that z-score. It's the more highly connected, or the more high outflow regions. As we resect these higher and higher outflow regions, we see an increasing likelihood of seizure freedom that gets as high as almost 90%. And conversely, when if we look at the red line, it's the negative predictive value. In this case, it's answering if we leave these high outflow contacts behind, what is the likelihood of seizure freedom? And as we leave more of them behind, the likelihood of seizure freedom drops to as low as 10%. So at the individual level, here's another way of looking at these data. Again, the red lines are people who had ongoing seizures after their surgery, and the blue lines are people who did not have any seizures after their surgery. And the longer this line is to the right represents the more of these really high outflow contacts that were resected, and the longer the line is to the left, it represents the more of those really high outflow contacts that were not resected. And what you may notice is that there's a lot of red here on the left, where all of these electrode contacts, these high outflow electrode contacts, were not resected, and a lot of individuals continued to have seizures. Whereas in those who had a resection of those high outflow electrode contacts, a lot of them did achieve seizure freedom. And so my hope is that, you know, these data to me are really promising, right? If a lot of children come in with a 50% chance of having seizure freedom, and we can say, oh, you know, based on these networks, if we leave this stuff behind, if we leave this part of the brain behind, there's actually only a 10% chance of seizure freedom, then you might decide not to go through with the surgery. Conversely, if we can say, actually, you know what, if we just extend the surgery out a little bit further and take these regions, then it's not a 50-50 chance of seizure freedom, it's actually an 85% chance of seizure freedom, then that's great, right? Then we can improve those numbers and improve people's lives. So the next things that we need to do first are to validate the utility of these intracranial EEG-based spike-associated networks. And I've recently gotten funding to do that. So we're going to take the 22 children that we included in the original study. We're going to include adults as well, and we're going to try to extend it out to about 100 individuals and see, you know, do those outcomes that we saw in the first cohort hold up? Does it really look as promising as the original data suggest? And then we want to ask, are there network features that might be more predictive of the outcome? So I just use this term high outflow contacts, right? The ones that just were sending a lot of information out, but it might be more complicated than that. It might be that there are certain parts of the brain that are only sending a little bit of information out, but the information that they're sending is critically important. And maybe those are the parts of the brain that need to be removed or ablated. And so we're going to use some different types of analyzing networks to try to understand whether there are other features of these epileptic networks that could help us further improve on this method. And then finally, is another area of my own interest is in these cognitive challenges. And so the question is, you know, when we do the surgery, depending on where this epileptic network extends, do we think that we might see some improvements in your child's cognition afterwards? And my hypothesis here would be if the epileptic network extends out into parts of the brain that are responsible for certain types of cognition, say your language comprehension or your impulse control, then I would predict that stopping those seizures would lead to some improvement. Whereas if the network doesn't involve those brain regions, then stopping the seizures might not lead to an improvement at all. And maybe we need to, counsel differently or just think about other approaches to helping with those challenges. And so that's something that's on the near future of my goals for applying this technique. So that's all I have for you today. Obviously, it takes a ton of people to do any sort of research project. So a big thank you to all of my mentors who have helped me, a lot of collaborators, both here at Children's Hospital and at the University of Colorado, my several research assistants, my funders, and of course, the patients and their families who trust us with their care. Thank you very much.